Very good morning to everyone. Today's topic on general principles of periodontal surgery. These are the contents where we are going to see. Objectives like removal of the pocket by surgical means, which is the pocket which is established in environment conducive to progress of periodontal disease was eliminated, and also root surveillance for tooth cleaning and after healing. Signs other than increased probing depth should be present to justify surgical therapy, like abrasion of gingival morphology. Indications like correction of mucogingival problems, persistent inflammation with deep pockets where phase 1 therapy is not in case of grade 2, grade 3 furcation involvement, area with irregular bony contour, deep crater, other requirements. Contraindications, patient with any systemic problems like CVS, CNS, malignancies, patients of advanced stages where tooth was lost for life without restoring the radical treatment, in presence of active heavily infections where patient mood is inactive, results in phase 1 therapy itself. Fundamentals like base is more than free margins. Incision like periodontal surgery involves use of horizontal and vertical incision. 15 or 15C blade can be used. Can you see the scalloped incision where it follows the morphology of the tooth, and the straight incision which is directly can be used. Incision of flap, can you see this one? The A, B, C, and this is the picture which is in Carranza itself. You can see the first is internal bevel, it's pointing towards the alveolar bone. Second is clavicular, that also pointing towards the alveolar bone, but it's inside the crevices. Followed by third is internal incisions. Internal bevel incisions to reflect the flap elevated and tissue colors. It remove the pocket lining also. It is a sharp thin flap margin for adaptation. Clavicular incision is called intracervicular incision, intrasulcular, sulcular, intrasulcular, whatever the things are the name. But it is the second incision where the cervical margin, submarginal incision can be done in external bevel and internal bevel. Can you see this one? When keratinized tissue is abundant, submarginal incision can be given. Whereas in keratinized tissue is limited means a submarginal incision in a keratinized tissue, and a crustal incision maximizes the keratinized tissue. Vertical incision, splitting the papilla, preserving the papillas, long, narrow, broad, facial surface not made in the center of the internal papilla. So these are the flap types which we have discussed earlier. On this picture, can you see in this full thickness flap, periosteum is elevated off the bone by blunt dissection. In partial thickness flap is splitted by sharp dissection. One part of the periosteum is continuously intact over the bones. Okay. Some of the general principles are outpatient, preparation in the patient, rehabilitation after phase 1 therapy, pre-medication, smoking, informed consent. So rehabilitating phase eliminate some lesions entirely, render the tissue firm and consistencies. So rehabilitation, reprobing can be done. So emergency drugs should be there for surgical therapy like oxygen, oral glucose, salbutamol 100 mg, adrenaline, glycerol trinitrate, aspirin, midazolam will be there. Sedation, pain control in periodontal surgery is important. The most reliable means of providing painless surgery is effective administration of local anesthesia. Apprehensive neurotic patients may require special management, but specific agents like modality of administration are based on desired level of sedation, the anticipated length of the procedures, and overall condition of the patient. The patient medical history and physical and emotional status should be considered when determining the need for sedations. Hospital periodontal surgery, some of the indications are control and management of patient with severe anxiety apprehension, optimal safety for individuals who cannot endure multiple extensive visits, optimal medical management of older and severely deliberated or medically compromised patients. Patient anxiety and apprehension, gentleness, understanding, preoperative sedation usually suffice to calm the fears of the most patient. Explaining that the treatment at the hospital will be performed painlessly. Tissue management, operate gently and carefully. So observe the patient at all the times, that is facial expression, pallor, perception. Be certain that the instruments are sharp. Instruments are sharp to be effective treatment. Dull instruments inflict unnecessary trauma. Scaling and roopling, all exposed roots after scaling and roopling should be carefully explored and planed as need for areas of difficult areas like furcation, deep infra-bony working must be checked for rough areas or even calculus that was undetected during the preparatory surgery. The exposure obtained to the subgingival root surface and flap is reflected allowed access for root therapy and altered by existing osseous defect. Hemostasis, that is you have to control the bleeding, that is hemo means blood, stasis means that is in a constant level. So you have to control the bleeding, accurate visualization of the extended disease, pattern of the bone distribution, anatomy and condition of the root surface. Good hemostasis prevents excessive loss of blood in the mouth. Control of intraoperative meaning application of pressure over this region. You have to dip the gauze in the LA solution and you can apply over that region. Excessive hemorrhage means laceration because of laceration of venules, arteries are large. Laceration of medium and large vessel rare because incision nearly highly vascular anatomic areas. Some of the absorbable hemostatic bonds, absorbable is there, oxidized cellulose is there, oxidized regenerated cellulose is there, oxidized gelatin sponge may be cut into various sizes and you can keep over it. But it should not be overpacked on the extraction site because it may interfere with the healing. Oxidized cellulose like extremely friable will be there, and oxidized regenerated cellulose should not be placed in deeper wounds. Coming to periodontal dressings. At completion of the periodontal surgical film, clinician may elect to cover the area with surgical dressing, mainly for promote the healing, reduce the food debridements, or they protect the patient from pain. Zinc oxide eugenol dressing is that it is developed by Wanterpack, which was developed by Ward in 1993. The addition of accelerators such as zinc acetate gives the dressing a better working time. Zinc oxide eugenol dressings are supplied as a liquid and powder that are mixed before use. Eugenol in this type of dressing may induce an allergic reaction that produce redness of area, burning pain in some patients. This is the non-eugenol pen. Can you see the base and the catalyst? Two tubes will be there. One tube contains the base, that is zinc oxide, an oil for plasticity, a gum for cohesiveness, lorothidol fungicides will be there. Catalyst, another one, it's coconut fatty acids thickened with chloropyracin, chlorothiamine. Other non-eugenol dressing include cyanoacrylate, tissue conditioner, and ethyl acrylate. This is the preparation. Make sure that you have to induce the equal amount of base in the catalyst. Gently mix in a circular motion and can place it, loosen its tackiness. You can place it over this region and you can apply a gentle pressure. Can you see inserting the periodontal? A strip of packet hooked around the last molar and pressed into place anteriorly. The lingual pack is joined to the facial strip at the distal surface. Gentle pressure on the facial lingual surface joins the interproximally. Some of the post-operative interventions are take 2 Tylenol, that is acetaminophen, NSAIDs, you can know that every 6 hours. For the first 24 hours. Do not take aspirin because this may increase the bleeding. The dressing should remain in place until it is removed in the office at your next appointment. For the first 3 hours after the operation, avoid hot food, avoid hot liquids, semi-solid fine minced food only. Citrus foods avoid, fruit juices, highly spiced foods also avoid. Do not brush over the dressing region. Brush and floss the area of the mouth that are not covered by the dressing. Use Chlorhexidine like Peridox, Perigord can be used. First, patient should be instructed to rinse with 0.12% of Chlorhexidine immediately after surgery and twice daily until normal biofilm control can be resumed. Some of the following complications we can say: persistent bleeding, that is dressing is removed, local anesthesia might be needed before the bleeding area are located. Sensitivity to percussion like extension of inflammation, dressing should be removed and the surgical area checked for localization of infection or area. Relieving the occlusion can be helpful. Sensitivity to percussion may also caused by excessive dressing which interferes with occlusion. During the first 2 post-operative days, first 2 days of post-operative period, swelling might be expected. Lymph node enlargement may more increase in temperature will be there. It may result from localized inflammatory reaction. When swelling persists means enlarges or is associated with increasing pain. Amoxicillin should be taken every 8 hours for 1 week. The patient should also be instructed to apply moist heat intermittently over the area. Findings at the time only: if gingivectomy has been found, the inside surface is covered with fibrous meshwork of new epithelium. If calculus has not completely removed, red bead-like procedure. Granulation should be removed properly. After flap operation, the area that corresponds to the incision epithelium, but they may bleed readily if infiltrated. Fragments of calculus delayed the healing. The root surface may be sensitive to touch or thermal, which will be disappeared within 4 to 6 weeks. Some of the mouth cares can be care of the mouth by patient between the treatment as well as surgery is completely extremely the patient should use a soft brush, light water irrigation. Vigorous brushing should not be advisable for first few weeks. Rinsing with Chlorhexidine mouthwash or apply a rinse topically with cotton tipped applicator better. Patient should be told to some gingival bleeding will occur. This bleeding is normal. Bleeding should not determine following their oral hygiene. Some of the managements of post-operative pain are: severe pain means control of pain is an important periodontal management. A common source of post-operative pain is periodontal dressing. So overextended dressing causes localized edema. Removal of excess dressing is followed by resolution. Extensive prolonged exposure of bone with pure irrigation during surgery induces greater pain also. For most healthy pain, a preoperative dose of ibuprofen 600 to 800 mg followed by 1 tablet every 8 hours for 24 hours effective. Coming to the conclusion, the efficient, precise and minimally traumatic management of tissue is necessary to achieve the most predictable and comfortable result and outcome for the patient. During the immediate postoperative weeks, biofilms control and healings are enhanced by the use of antimicrobial mouth rinses such as Clonca. Also, you can use post-surgical pain like bupivacaine, local anesthesia, long-acting bupivacaine can also be used. Post-surgical root sensitivity is well controlled by ensuring that the biofilm control is optimal. So these are the references you can see in Karanza's. You can use Linde 6th edition. It is better. Thank you.